Okay, so we did aortic stenosis last couple of weeks. I think we have exhausted aortic stenosis, and you should know everything about aortic stenosis. We're going to move on to aortic insufficiency. So, and the term suggests when something is insufficient, then it's not competent. All right. Um, in specific, what we're talking when we say aortic insufficiency, what we're talking about is the backflow of blood from the aorta into the left ventricle. As you recall, the normal flow of blood is from the left ventricle. When the left ventricle contracts, blood will flow across the left ventricular flow tract, across the aortic valve and into the aorta. That's a normal flow. But if the aortic valve is incompetent, for whatever reasons, and we'll look at some of those reasons, then in diastole, the blood will flow backwards across the aortic valve and into the left ventricle. So, what are some of the signs and symptoms of aortic insufficiency? A lot of cases, the patient come to the echo lab for a routine study or for a study for whatever reason, and we pick up some amount of aortic insufficiency. The aortic insufficiency can be mild, moderate, or severe. Patient may be completely asymptomatic. Okay, so it may just be an incidental finding. Patient come to the echo lab for some other reason, and we pick up the aortic insufficiency. However, if the patient has symptoms related to the aortic insufficiency, then it can be shortness of breath, and we call it dyspnea. So the shortness of breath, if it's related to the aortic insufficiency, it will be shortness of breath with exertion at first. So it will start out as shortness of breath with exertion. Then as it gets more severe, then you can get shortness of breath at rest. Patient may also have what we call orthopnea. And orthopnea is the inability of the patient to lie flat. They have to prop themselves up. So you'll ask, how many pillows you sleep on. Some patients will tell you they sleep in a chair upright. And then we have paroxysmal nocturnal dyspnea. That is, after the patient go to bed and they're sleeping, they have to sit up to breathe because uh, when you assume the recumbent position, when you lie down, fluid from the interstitial space goes into the intravascular space, and you have increased intravascular flow volume, and then the lungs become flooded with fluid. And so after a few hours of lying flat, the patients have to sit up in order to breathe. So that's paroxysmal nocturnal dyspnea. Palpitations, um, if the, the cardiac output is reduced, then the compensatory mechanism, you get increased heart rate, patient develop a tachycardia, and it'll tell you I have a palpitation. But there can be other cause for the palpitation. You can have premature atrial beats, premature ventricular beats. You can have even a ventricular tachycardia. So palpitation, that patients are aware of their heartbeats. Chest pain, they can develop, angina. It's not uncommon. Third heart sound, which is a sign of heart failure. Um, and the classic murmur for aortic insufficiency is a blowing diastolic murmur or at the left sternal border. And we call it a decrescendo murmur. It starts high and then it sort of get lower. Okay, so decrescendo. All right. So what are some of the causes? What are some of the causes for aortic insufficiency? So anything that causes aortic root dilatation, because if the aortic root is dilated, then it's going to pull the cusp and the aortic leaflets apart. So in diastole, when they're supposed to close, there's going to be a gap in between the cusp and the leaflet. So anything that causes aortic root dilatation, you can name it. There's a lot of things that cause it. Syphilitic aortitis, which eventually can cause aortic root dilatation, but it can affect the cusp and the valves and deform the cusp and the valve, preventing proper coaptation. Aortic dissection, that is when you have a rip in the wall of the aorta, and if it goes backwards towards the cusp and the valves can become incompetent. Hypertension, for the same reason, they cause dilatation of the aortic root, improper coaptation of the leaflets, and aortic insufficiency. Bicuspid aortic valve. So again, you know that bicuspid aortic valve is one of the leading causes of aortic stenosis in younger patients, patients under age 60. It's also a very common cause for aortic insufficiency as well. Rheumatic fever, which can cause the aortic valve to become disfigured, and you can get either stenosis or insufficiency. Endocarditis. So endocarditis is when you have an infective material on the valves, and if it's on the aortic valve, then it's going to prevent proper closing of the aortic valve, so the valve is going to become incompetent. We about 15 years ago, we had weight loss medications uh, go by the common name fen-phen. It's really fenfluramine, and those medicines were pulled because they caused a valvulopathy. They could result in aortic insufficiency. So medications can cause it. Marfan syndrome, because Marfan syndrome results in aortic root dilatation and again improper closure of the aortic valve. Ehlers-Danlos can also cause it for the same thing, dilatation of the aortic root and improper closure of the valve. Ankylosing spondylitis and systemic lupus erythematosus, SLE. So these are some of the more common causes for aortic insufficiency, and you should be aware of them. So, you know, patient comes to the lab, um, you know, they have aortic insufficiency and they look marfanoid. So, you know, the patients who look marfanoid, they have their arm span is much greater than much greater than their height. Sometimes they have chest deformity. They have lens deformity as well. So they tall. They're very tall and skinny. And so you can look at your patient and have some sort of idea as to the cause. So once you make the assessment of aortic insufficiency, then you have to grade it. Okay, so one of the things that we do in echo, anything we find, we grade it, mild, moderate, and severe. So aortic insufficiency is no different, so we have to grade it, and it's very important to grade it correctly because, if someone have severe aortic insufficiency and other features, then we have to send them to surgery. So, if the aortic insufficiency is severe and they're symptomatic with shortness of breath, evidence of heart failure, then we have to send them to surgery. If the patient only have mild aortic insufficiency and have significant shortness of breath, then the shortness of breath is not because of the aortic insufficiency. So you have to look for something else. So there are a few methods that we use for grading, and one of them is, relatively simple. We look at the jet. So this is your parasternal long axis. This is a diastolic frame, and you can see the aortic insufficiency. Okay, so the aortic valve supposed to be closed, but when you look, you see blood is flowing from the from the aorta across the aortic valve into the left ventricular flow tract. So what you do, you measure. So you come into the left ventricular flow tract, you measure the diameter of the regurgitant jet, and you give it as a percentage of the left ventricular flow tract. So the width of the regurgitant flow, using the color flow, to the width of the outflow tract. Okay, so that's the outflow tract, left ventricular flow tract, just like when you measure the diameter. So you measure that, and then you measure the width of the regurgitant jet, just a little, a little way out from the valve, and you give the percentage of the regurgitant jet uh, to the left ventricular flow tract. If the proximal jet width ratio to the LVOT diameter is greater than or equal to 65%, then we say the aortic insufficiency or the aortic regurgitation is severe. If that proximal jet width ratio to the left ventricular outflow tract diameter is less than 25%, then we say the aortic insufficiency is mild. Okay, so this is one of the first thing we do, the first step in determining the severity. So the width of the outflow tract, you can see the outflow tract, and we did this when we're doing aortic stenosis, and then you measure the width of the regurgitant jet. The ratio, greater than or equal to 65% severe, less than 25% is mild. So anything that falls in between these two numbers is moderate. The other thing we use is the C doubler, the Doppler of the AI jet. And we usually do this in the 5 or the 3 chamber view. So this one is actually a apical 3, and you put your continuous wave Doppler in the left ventricular flow tract. And again, if you remember, you're going to get a diastolic envelope because aortic insufficiency occurs in diastole. Your ECG is on top. Diastole is from the end of the T wave to the QRS. So you see this envelope occurs only in diastole, and it's decrescendo. It starts at a peak and it gets less. So that's why we call it it's decrescendo. So what we look at is the pressure half time. Okay, the pressure half time, and when you're doing your study and you put your cursor at these two, your sample volume at these 2 points, the machine will give you a pressure half time. If your pressure half time is less than 200, your aortic insufficiency is severe. If it's greater than 500, then your aortic insufficiency is mild. Anything that falls in between is moderate. We also look at the density of the AI jet, the density. If it's faint, this is relatively faint, then we would say it's mild. If it's very dense, dense like say your aortic jet, if it's very dense, then it is severe. Okay, so the pressure half time, less than 200 severe, greater than 500 is mild. Anything that falls in between is moderate. The density of the envelope, if it's very dense, it's severe. If it's faint, then it's mild aortic insufficiency. All right. And all right. All right. So this is just a comparison. So again, your parasternal long axis view, and you do your color. You can see the little aortic insufficiency jet there. So we'd measure the diameter of the jet. I will measure the diameter of the LVOT and get the ratio. If it's less than 25%, then it's mild. Then we'll do the C doubler, and we do this either in the 5-chamber or 3-chamber view. If it's faint, not very dense, suggests it's mild. If the pressure half time is greater than 500, then it's mild. You have to remember the relationship between deceleration time and pressure half time, especially in the exams. Sometimes they'll just give you the deceleration time, assuming that you know the relationship between deceleration time and pressure half time. The relationship is pressure half time is equal to 0.29 times the deceleration time. Pressure half time is equal to 0.29 times the deceleration time. All right, so the next thing you're going to do, you're going to get a P doubler across the descending aorta. So when you do your suprasternal notch view, one of the things you do, you put your Doppler in the descending aorta, and it's very important. So normally we'll get this nice brisk systolic flow and nothing much in diastole. So this is what we'd expect normally. Okay, this is what we'd expect normally. So all of these findings or features suggest mild aortic regurgitation or mild aortic insufficiency, as opposed to the lower scenario, parasternal long axis view. If you measure the width of this AI jet to the left ventricular flow tract, the diameter is greater than 65%. If you look at the deceleration time here, it's less than 200. And look at the density of the C doublet. It's very dense, very dense. So this is suggesting severe, but when you come to your descending aorta, you do your suprasternal notch view, and of course you're going to get your nice systolic flow, but you get an diastolic flow reversal. So remember, we usually don't get anything in diastole, but now you get a flow in diastole, and it's reversed. So diastolic flow reversal, and that is usually suggestive of severe aortic insufficiency. So putting all of these things together down here, okay, suggests severe aortic insufficiency. You have to remember these things, because when in evaluating a patient with aortic insufficiency, one of your job is to determine the severity. If you don't do all the stuff, I am going to be guessing when I'm reading it. So you have to do everything so that I have all the tools in hand to make a good assessment. All right, so we also use the PISA method to evaluate aortic insufficiency. As a matter of fact, it's one of the most accurate method to determine the severity of aortic insufficiency. And again, just to recap, PISA stands for proximal isovelocity surface area. Okay, and remember how we do that. You across the aortic valve, you're going to have all right, so let's just go back. So if you have the regurgitation going this way, then the PISA is going to be on the opposite side, okay? All right, the PISA is going to be on the opposite side. The regurgitation is there, PISA is going to be on the opposite side. So again, proximal isovelocity surface area. When you measure the vena contracta, if it's greater than 0.6, it is severe. Okay. If it's less than 0.3, then it is mild. Okay. So vena contracta. Remember, the vena contracta is the narrow portion. So when you have the regurgitation, let me sort of recap that a little bit for you. So, all right, so we're just going to recap. All right, so if we have, say this is a valve, any valve, the same concept holds. So this is a valve, and if we have, say, the regurgitation is right here. The regurgitation is down here. Okay, then up here we're going to have the PISA. So remember the PISA, proximal isovelocity surface area. It's a hemispheric shells on top, hemispheric shells on top. And if you were to take out the PISA actually, you're going to have a narrow neck, and then you have the hemisphere right there. This narrow neck is what we call the vena contracta. Just the width of the neck is what we call the vena contracta. So what we're saying, if the vena contracta is more than 0.6 centimeter, then the AI is severe. If it's less than 0.3, then it's mild. Remember, the EROA, which is the effective regurgitant orifice area, is actually the area through which a regurgitation is occurring. So remember, the regurgitation is coming down here. So this is the regurgitation right here. But the blood has to regurgitate through a area, a potential space. And that area can get larger if you have a large amount of blood regurgitating. It can get smaller if you have a small amount of blood regurgitating. Okay? So, and we showed you how to calculate the EROA. If your EROA is greater than or equal to 0.3 centimeters squared, then the AI is severe. If the EROA, the area through which the regurgitation is occurring, is greater than or equal to 0.3 centimeters squared, then it's severe. If the area is less than 0.1 centimeters squared, then we say it's mild. Okay? Also, we talk about regurgitant volume. So it's the volume of blood that's regurgitating. Okay? If that volume of blood is greater than 60 mLs, then it's severe. If the volume of blood is less than 30 mLs, then it's mild. And so the regurgitant volume. Okay, you have to memorize these numbers. It's very important because, especially when you're given tests, they will give you the regurgitant volume and ask you, is this mild, moderate, or severe? So again, if it's greater than or equal to 60 mLs, it's severe. If it's less than 30 mLs, then it's mild. And then the regurgitant fraction. If the regurgitant fraction is greater than or equal to 50%, it is severe. If it's less than 30%, then it's mild. We did all of these things when we did hemodynamics, so you should be familiar with it. Okay, so using PISA, these are the characteristics of severe and mild AI, and anything that falls in between is moderate. So again, vena contracta, very, very sensitive. Okay, very important, very sensitive. So if your vena contracta is greater than 0.6, severe, less than 0.3, mild. EROA, effective regurgitant orifice area, if it's greater than or equal to 0.3 centimeters squared, severe, less than 0.1, mild. Regurgitant volume, greater than or equal to 60 mL, severe, less than 30 mL, mild. Regurgitant fraction, greater than or equal to 50% is severe, less than 30% is mild. So again, there's no other way. You have to memorize these numbers, so you can determine the severity of the yeah. Okay, so now we come to the table. So this table you have to memorize, okay? Because as a matter of fact, you need to put this up in wherever you do echo and use it until you memorize it. Okay, again, so severe AI, when you look at your color flow jet, okay, and you're going to do this in the parasternal long axis view, if the width of the jet to the width of the LVOT is greater than or equal to 65%, it suggests that the AI is severe. If the vena contracta is greater than 0.6 centimeters, suggests severity. Your pressure half time less than 200 suggests severity. If you get a holodiastolic aortic flow reversal in the descending aorta, remember the suprasternal notch view, and you get that holodiastolic flow reversal, suggests severity. And if you have moderate or greater LV enlargement, so if the LV is enlarged to a moderate or greater amount, it suggests severe aortic insufficiency. The regurgitant volume, anything greater than or equal to 60 mLs, regurgitant fraction greater than or equal to 50%, and the EROA greater than or equal to 0.3 centimeters squared. So these are all the parameters for severe AI. Now, if you have only one of these things been positive, then you can't call it severe AI. You know, if you have multiple of these parameters satisfying the criteria, then yes. Again, one of the most sensitive method is using the vena contracta, okay? Where you should measure that, you should do your pressure half time, look for your holodiastolic flow reversal, so you get as much parameters as possible. Don't just get two and then expect, you know, the person who is interpreting the study to come up whether it's mild, moderate, or severe. So the more of these things you get, then we can make a more accurate assessment. And then for mild aortic insufficiency, if the width of your regurgitant jet to the outflow tract is less than 25%, it suggests mild. If the vena contracta is less than 0.3 centimeters, suggests mild. Okay, if you don't have your holodiastolic flow reversal in the descending aorta, then that also suggests mild. Pressure half time greater than 500 milliseconds. If the LV size is normal, if your regurgitant volume is less than 30 mLs, regurgitant fraction is less than 30%, and if your EROA is less than 0.1. So again, you need to memorize this table so you can determine what's mild, what's severe. Anything that falls within mild and severe, then it's moderate, okay? So, all right. So that's aortic insufficiency. Again, go over the lecture multiple times.